So my name's Krista, and this is my partner Luke, and we work for Medtronic Deep Brain Stimulation. I want to thank Susan and Candace and everyone here at Parkinson's Place for allowing us to come in today and talk to you about our exciting new technology. So with that, let's get started. Okay, Luke and I. Okay, so I know this presentation is about adaptive DBS, but I thought it would make sense to start at the beginning and explain what DBS is first. So what is DBS therapy? And has anyone heard of it, had it done, or currently thinking about it? Heard of it? Okay, good, good. Awesome. So DBS delivers controlled electrical stimulation to the brain to block some of the brain signals that cause the movement symptoms of Parkinson's. It is an established, safe, and effective therapy, FDA approved since 1997 for tremor and 2001 for Parkinson's. So this technology has been around for a long time, and over the years, technology has improved to bring us our newest revelation, which is adaptive DBS therapy today. DBS is reversible and it won't limit your future treatment options. And unlike some brain surgeries for Parkinson's, DBS can be turned off or removed completely. And on the side here is just a little graphic showing you that the leads are placed in the brain, which are attached to some extensions that run down the side of the neck into a neurostimulator or a pacemaker-like device in the chest. So that is what a complete system looks like. Okay, so what are the benefits of DBS? So some of the benefits include improved motor symptoms and more on time, reduced medication, improved quality of life, and 24/7 therapy without wearing off. We're going to dig a little bit deeper into the last bullet to show how adaptive DBS differs from regular or continuous DBS. And it's also important to note that DBS is not for everyone, and not everyone who receives DBS will receive the same results. Slide on some of the safety and risks. As with any surgical procedure, there can be risks, surgical risks, device-related complications, neurological or psychiatric symptoms, interference with other medical devices. So as always, it's important to consult your physicians and find potential risk for this therapy with your doctor. So when should you consider DBS?
Can you guys hear me? Hey, how you doing? So let me jump in and kind of help describe this one graph. I think a lot of people might have seen this before. It may look familiar, but when someone is diagnosed with Parkinson's over the years, what ends up happening is that they start having to deal with more and more symptoms. And so then try to meet up with a specialist, a neurologist, like a movement sort of neurologist that knows how to manage Parkinson's the right way, right? These are the professionals that have spent their life training to manage Parkinson's. And the reason why we like to show this graph is because it kind of describes a little bit of what a day looks like with someone with Parkinson's as the years go by. Over time, what happens is that you tend to have these fluctuations throughout the day, meaning when you wake up in the morning, that's typically when your medication is worn off throughout the night and you're feeling off, and you typically take that medication to try to help you with your symptoms. And as the body absorbs the medication, you come off, these symptoms and you start feeling a little better. So you find yourself in this window where you're on, but without motor complications. And if you've met someone or yourself, find yourself in a position that in some instances, you start getting these dyskinesias, which are these involuntary movements that you get.
Yes.
These are the kind of the roller coaster ride that someone can experience. And as Parkinson's progresses, you might find it happen more often throughout the day, right? So our ultimate goal is try to find a way to get you into this on time, but feeling your best without motor complications. And this is where DBS comes into play.
Okay, with that said, who is a good candidate for DBS? You may be a good candidate for DBS if you've had Parkinson's for 4 or more years. you have had movement symptoms and or medication side effects for 4+ months, as in what Luke described, those medications aren't working as well as they used to, and you're having some of those fluctuations throughout the day. You are levodopa responsive, so when you take the medication, it does help with the symptoms. And you have movement symptoms that are not adequately controlled by medication. Okay. When is the right time for DBS? So this slide is so important because oftentimes we hear patients say, my symptoms aren't bad enough yet, or I'm not ready. Although that may be the case, we actually recommend DBS earlier in the disease process while you're still living your life and able to do everything you need to. There's a window of opportunity and around the 4-year mark when medications aren't working as well as they used to. However, if your symptoms no longer respond to medications or you are no longer a surgical candidate, DBS may no longer be an option. So the best thing that you can do is educate yourself, ask questions, talk to your doctor. If this is something that you're really considering, just make sure you do all of this early so that we don't surpass this window, because it can be a really beneficial therapy for the right people.
Chris, if I can just add something. Krista did mention how important this is, and I've been with Medtronic over 12 years now, and have built some great relationships with a lot of the movement disorder neurologists and the surgeons in our area. And what tends to happen, I think, in the journey of Parkinson's is sometimes no one shares with you that you have Parkinson's until later in life, right? A lot of times people are being managed by primary care physicians or then a neurologist, and maybe at some point you find yourself being managed by a movement disorder neurologist. And I think that's probably the biggest step for someone that's experiencing Parkinson's is find yourself a good movement disorder neurologist that knows what they're doing. And the importance of that is because they are experts at this. They really know how to manage medications, and they understand all the different classifications that are out there and how to manage them and mix them up, okay? But it's this stage where you are presented with possibilities of what might come down the road, because the body is starving for dopamine, and we try to give them different types, but at some point you start getting these motor fluctuations, and some of these motor fluctuations is due because the part of your brain is not producing the dopamine that it wants to, right? It's called the substantia nigra. It starts over time not working as well as it used to. And so the receptors in your brain are trying to find dopamine to try to help you move properly. But because they don't have it, we don't have that production, the brain automatically adds more receptors and goes, I need to try to find more. And what happens there is that then when you take your medication, it takes up too much, and that's where these dyskinesias come in place, right? So over time, you're going to have these fluctuations. So by learning what DBS is, you start getting maybe more comfortable with the idea that that's a possibility. And when the window opens up, that's when you can have these discussions with your movement disorder neurologist and say, hey, should I really be considering this? Is this something I should do? Because the reality is that DBS, as of today, is the best therapy available for Parkinson's on the market, okay? It's just not everyone's going to do it at this stage because we have awesome medications. If you could be controlled by medication, great. What happens is that if you don't learn, you find yourself here. People think of it as a last case resort. It's so, your Parkinson's reaches a point where you think, okay, I need to consider DBS, and then that may no longer be a good window. So when you educate early, you won't find yourself as much in that bucket, but you can make good decisions because you've had good information throughout your journey.
Yeah, very well said.
Yeah. Yeah, that's a good question. When people are not well educated and not, meaning someone says, yeah, just go have DBS. Let's say you go to a center that's not as well, they don't have the experience maybe as other centers have with DBS, and they still implant at this stage. That could hurt someone more than help someone, right? Because you may have, Parkinson's can can be detrimental to your cognition, right? You may have balance issues. You may have speech issues. All these things are items that we'll cover in a minute. They don't really improve with DBS. Here, when you do it here and you don't have these other things I mentioned, your body is not going to go downhill from that point. It's going to hopefully stay the course. At some point, the disease is still progressing, but you want your quality of life to be good throughout this entire process. Once you're here, your options are fewer, right? And so what Krista said is important. You want to be able to enjoy when you still have good motor skills and you're still moving around, you're still active. DBS can prolong those days of not having these fluctuations, but staying in the middle so that you can enjoy the days when you're still active and can do it versus waiting until the last bucket.
Mm-hmm. Awesome. Any other questions? Okay. I love that. Okay. What to expect with DBS? We'll quickly run through what the implant process looks like, then dive into programming DBS, and then lastly, living with DBS. With programming, that's when we're going to really talk about where our electrode identifier and adaptive DBS come into play. So implanting DBS. The actual implant process is typically done in 2 stages. The first stage is the lead placement, and this is probably the most technical and I don't want to say difficult, but it's the longer surgery. In most cases, patients are awake during this stage. Another option is asleep. That really just depends on the surgeon. And then the second stage is where they place the extensions and the battery into the chest. This is just a quick outpatient procedure and you get to go home the same day. Once you have the full system implanted, 2 to 4 weeks later, you will meet with your movement disorder neurologist for your initial programming, where we will find the settings that work best for you initially. This is just a little slide that shows our Sensite directional leads. So this is what the lead implanted in the brain actually looks like. It has 4 different contacts, and we are able to use a directional stimulation so that we can steer the current to best control the symptoms without causing any side effects. This gives us the best opportunity to give us options to find what settings work best for you. Even as the disease progresses, there are tweaks that we can manage down the line during our programming sessions to make sure that we are staying up to date with your symptoms.
Yeah, if I can add something, Krista. Just to give you guys some background about Medtronic, we've been in the field. We are actually the originators of DBS. We started this technology. This happened in the mid-'80s when we had our first implant in France, Grenoble, France, with Dr. Benabid, using electrical stimulation to help Parkinson's symptoms, essential tremors, and others. Since then, we've had multiple iterations of our technology. And what Chris is going to point out is our latest technology, where we are today with it. We've partnered up with so many different physicians, clinicians, researchers to develop a technology that is more personalized and catered to an individual versus blanketing it over the entire Parkinson's kind of community. And so today, Chris is pointing out the latest technology that we have that truly does have a personalized concept versus just one size fits all, basically what I'm trying to say.
Okay. And like Luke said, at Medtronic, we like options. So we have 2 available neurostimulators. One is recharge free and the other is rechargeable. They both share the exact same brains and have the exact same capabilities. The only difference is one is non-rechargeable and the other is rechargeable. The non-rechargeable will last anywhere from 3 to 6 years, depending on the amount of energy required to control symptoms. And the rechargeable will last at least 15 years. which is great. And then there's just a little bit more responsibility on the patient to stay up with the recharging, typically about once a week. Okay, now we're getting into the fun stuff. So I think you all can relate when you have an office visit, you're trying to paint a picture of what your life is like in a 15-minute window. It may be hard to express or describe what your day-to-day looks like, and BrainSense can help paint that picture for you. So Medtronic DBS is the only system that offers our BrainSense technology. It is a technology that continuously captures and records real-time brain signals related to your symptoms, provides a more complete picture of your day-to-day activities at the time of symptoms, even when symptoms occur outside of the clinic. And it helps your clinician adapt your stimulation to your individual needs to personalize treatment and minimize side effects. So with the graphics on the right-hand side, this is an example of our tablet and kind of that data that we look at with the clinician. As you can see, the patient walking normally, and we don't see, any interesting data on the graph there. And then on the graphic below, we see that he's having some movement symptoms such as akinesia or rigidity. And you can see how the system has picked up a small peak there. And that is to show that we can see these beta waves or signals in the brain that are correlated with symptoms of Parkinson's, such as the rigidity, bradykinesia, and also tremor, so that we can track this, and it helps give us and the clinician more information to make decisions about your care.
Yeah, let me add a little bit more to that. So I talked about the research that we partnered up with a lot of the physicians out there. Our clinicians and researchers want to find out more about Parkinson's, right? They want to know what we need to find out more. Is there anything in our brain that can tell us information that can help us not only hopefully find a cure at some point, but how can we manage Parkinson's differently? Okay. And the reality is this person's Parkinson's could very well be different than this person's, and this person's and different this person. So no one has the same Parkinson's. Everyone says when you meet someone with Parkinson's, you meet one person with Parkinson's, right? For some people, it's balance. For some people, it's rigidity. For some people, it's tremor, or a combination of all of them. And it's hard for a movement disorder neurologist or someone in front of a movement disorder neurologist explain exactly what that day looks like. They try to give as much information, but the reality is you got a 15-minute window, like Krista just said. And when you walk out, you probably go, boy, I forgot to talk about this, or I forgot to share about this, right? Why we are excited about brain sensing is that we now have the only technology that can tap into a signal of the brain that researchers have found happen to fluctuate in correlation with that same roller coaster graph that I showed you, where when you're not feeling well, that signal is very strong in the brain. But when you take your meds or they turn on the stimulation in the DBS, the signal strength drops. So we can see with the information that we pull from the individual's brain when you're not feeling good or when you're feeling good, right? And it'll map it out on the clinician's tablet and show how it fluctuates. This is a bit of an exaggerated, motion, because I wanted to show you kind of what it looks like. Let's say you're sleeping, you're not doing too badly. You wake up, the signal increases because you're off. You take your meds and it slowly drops down. And then you have that roller coaster ride. All right. That's the really neat thing about this technology. Today, we could only collect that information, right? And then the neurologist would go, all right, I noticed that around 6 a.m. you don't do well. Well, what time do you take your pill? 7 o'clock? Well, why don't we take a little earlier? So that's information that the neurologist never had in the past, right? It's you trying to explain to them, oh, you're not doing too well at this time? Well, let's see if we can change things. But also, when you have DBS, when we turn this on, want to see this all start dropping and have more of a flat line versus these peaks. So with a combination of our technology and the neurology's expertise, they can manipulate our device, but also medications if needed, right? So it's a lot of interesting information that they can collect from your brain outside a clinic, not inside a clinic.
Awesome. Any questions about that? I know that was a lot.
Yeah, my bad, but figured I'd share it with you guys.
Yeah. I'm gonna quickly just play a short video that explains kind of what we just talked about, but might make a little bit more sense.
When a person with akinetic, rigid Parkinson's disease exhibits near normal mobility, brain signals may show moderate synchrony with minimal frequency peaks. When a person with Parkinson's disease experiences movement challenges, brain signals may be excessively synchronous with a peak at the beta frequency band. The Percept PC implantable system for deep brain stimulation from Medtronic is the only system that can chronically detect and measure signals from the brain. BrainSense lets clinicians capture these signals from the brain both during and between visits, and this personalized information, along with other clinical information, may be used to inform clinical decisions.
All right.
That video did a much better job than I did.
It's pretty concise. Okay. Oops. Sorry about that. Okay. So now that we talked a little bit about what BrainSense is, let's move into why it's so important for our adaptive stimulation therapy. So the only sensing-enabled DBS system just got better. Introducing BrainSense Adaptive DBS, the world's first complete closed-loop DBS system. So this graphic looks very similar to the one that Luke talked about at the beginning. Managing each patient's disease can be complicated and time-consuming. And pre-DBS, as Luke said, medications are doing their best to try to keep you within that therapeutic window. And with DBS and that help of the movement disorder neurologist, medications, all that good stuff, we will try to get you optimized the best that we can and kind of keep you in that therapeutic window using our stimulation. However, as the disease progresses and you're just getting this constant stimulation, that may not be enough. We may need to increase, we may need to decrease, we may need to try different things. And then you get some of these fluctuations again. So with our adaptive technology, and if you think back to that timeline graphic I showed earlier, how we can look at those peaks on from the data that you came in, we can set thresholds that correlate with the data. So when your signals cross the threshold, the system will automatically recognize that and increase the stimulation to bring you back between the thresholds. For example, if you're having breakthrough tremor, if you're feeling more stiff than usual, the system will recognize that correlate with your brain signals to increase your stimulation so that you won't feel that. And it's nothing that you have to do personally. It all happens in the background from the device. Versus the other hand, if you take a medication and you're starting to feel a little dyskinetic and that signal is a little too suppressed, it'll drop below the bottom threshold and the system will recognize that and decrease the stimulation to bring you back up into those normal levels and help even out that dyskinesia.
Yeah, but I'll use this graph as an example. You have, you don't have DBS and you're being managed by medication. After DBS, things will get better and you're inside this window. Now, the adaptive DBS that Chris is talking about, just imagine you wake up and you're here and then you're starting to wear off, right? and your stimulation is let's say constant. As soon as it crosses a threshold that your movement disorder neurologist stores in your device, it'll kick in more stimulation without you having to ask it. It's your body asking the device for more stimulation. And imagine it not allowing it to cross here, and it keeps it underneath, and then tries to always maintain it inside this window, which is our goal when trying to treat Parkinson's. So this is an adaptive DBS system that's personalized to your signal, and it'll adapt based on what your body's asking.
Yep. So the system is on all day. It's constantly listening, constantly sensing to make the appropriate changes to give you the most on time and keep you feeling good the longest. So we talked a little bit about our adaptive DBS, and some of these next slides may be a little redundant, but we'll see where we get. On the other hand, we also have our BrainSense electrode identifier. So if any of you have ever had DBS or had an initial programming, typically the neurologist brings the patient in off medications to do this so that we can go through each contact on its own, check different amplitudes, different settings to try to find which helps best when you're off medication. And then you will take medication, wait another 30 minutes for that to kick in so we can see the interplay between medication and stimulation. This can be very uncomfortable for patients to be off medication that long. So with our electrode identifier, the neurologist or the clinician can complete the initial programming in less than 20 minutes, achieving comparable outcomes to the typical or traditional initial programming that clinicians are used to doing today. Okay. So it helps the clinician with increased in-clinic efficiency, 85% faster initial programming than the traditional way. Comparable clinical outcomes. So as we were talking about earlier, trying to find that beta and those peaks that we're looking for in BrainSense, we found that with our electrode identifier, it will tell us where the most beta is on the lead, so we can jump straight to that contact and know that that's the one that's going to work best for you. And then again, performing an initial programming in under 20 minutes so that you don't have that discomfort of sitting in an office for an hour or two off medications.
Yeah, I think, the overall goal is to try to get to the ultimate settings on your DBS system. And sometimes that process can take several visits, right? Just like any technology. The goal of technology is to make it easier for our clinicians so that they can get to that, perfect setting that suits you. This tool is just minimizing or reducing that time, because you run it and it'll highlight the sweet spot where it says, this is when we want to start stimulating. So it's something that we've never had in the past, and it fast tracks the process. Clinicians have been asking for more tools. This is one of them. As someone with Parkinson's, we also want to have more tools. So when our physicians have more tools, and the Parkinson's community also has more tools, because they can get to this information quicker.
Right. So as Luke was talking about tools, Medtronic DBS has tools for each stage of your DBS journey, starting with initial programming and electrode identifier, using our suite of tools to optimize your follow-up visits based off of your individual physiology, looking at that timeline with BrainSense and all of that information there, and allowing our system to follow you on your individual journey with Parkinson's. So we are selecting, we are optimizing, and we are maximizing therapeutic benefits over time.
This is probably the most important part of them all. DBS, for the last 25 years, it's been constant stimulation. You show up, you get DBS. It helps tremendously when it's done right and placed in the right place, and you have a good movement disorder neurologist that knows how to program. But the disease progresses over time. There's no technology out there that could give you information of how your progression's taken place, unless you've personally tell them, this is how I feel. This is the only system that can literally accompany you throughout your entire journey and collect data. And that data can be so informational to our movement disorder neurologists because they can go, boy, this looks different than this. What has happened? Did we change medications? Did that medication change? Have we tried all the medications? Or have we tried different settings? It's the only system right now that carries you throughout the entire journey.
Inside and outside of the clinic.
Yes.
Okay. All right. So as a recap, with our Medtronic BrainSense technology, it is personalized decision-making support for your clinician, giving them increased in-clinic efficiency and giving you improved motor symptom control. It's also designed for software upgradability, so there's no need for device exchanges. If you are, for example, implanted today, and we have an awesome technology that comes out, in 2 years, it's somehow better than a DBS. We would just upgrade your device. You wouldn't have to go get another surgery or anything like that. So always staying up to date with our latest and greatest. Okay. So this is just a little graphic that shows that patient fluctuations are not addressed by the INS. So this is typical or constant DBS. So this is what we have been using up to this point. And then with adaptive DBS, we're closing that loop. So instead of you having to go to your clinician every time that you need a change or, finicking with the adjustments, the system will recognize it and it'll do it itself. So the simulation is automatically adjusted in response to the patient's needs. Okay. So
yeah, we'll talk about tools. This is a slide that we share a lot with our clinicians, right? Because this is new technology to them. We talked about tools and kind of the different features that our clinicians have. Even with Adapt DBS, someone may respond to one type of adapting mode or better on a different adapting mode. So we're offering, there's actually 3 different types of adaptive stimulation patterns or stimulation modes that we offer. But all 3 of them fall into either a dual threshold or single threshold. And all we want to point out is we have more than one option for our clinicians when it comes to our adaptive technology.
So choose the Percept family with BrainSense Adaptive DBS to give patients with Parkinson's disease improved motor symptom control for more of their day. Okay, so living with DBS. Will I be able to resume activities? Yes, you can do everything and more that you were doing before. Can you travel? You can. We will give you a device identification card that you can take with you to the airport, wherever you travel. We typically tell people to say, hey, I have a pacemaker for the brain. Some people might not know what DBS is. Can I get an MRI? Yes. So Medtronic system is the only device that is 1.5T and 3T compatible for MRI. And in some cases, you can also keep your therapy on while you're getting the scan, which can really help. And can I check my DBS battery? Yes. Every patient that's implanted will have a patient programmer that you take with you at home, and you can use that to turn your device on or off, make any changes to your stimulation. Unless you're on ADBS, then you don't have to. And more.
Yeah, let me just, if I can just, I want to talk a little bit more about this one. Because there are different DBS systems out there, and they all have some sort of version of MRI compatibility, but it's all under something called 1.5T. That's just technical jargon of the types of MRIs out there, right? So the 1.5 and then the 3T, the 3T is what kind of really makes our system stand out, because not all MRIs are the same, and not all physicians or whoever, if you're in need of an MRI, a 3T MRI gives clinicians way more information on the type of the MRI they get. There's a lot more detail in that type of MRI. And sometimes that type of MRI is very much needed for whatever condition you're going through, right? And so having access to both of them really doesn't limit you or the physician that's needing the MRI to getting a good quality MRI, okay? So it's important to kind of point that out because we, not so long ago, did all the testing to get that new labeling, and it took a lot to get this labeling for us.
Some safety information. DBS for Parkinson's has established long-term safety and effectiveness through 36 months. Implantation of a DBS system is contraindicated for patients who will be exposed to diathermy or transcranial magnetic stimulation, and potential risks include bleeding, stroke, seizure, and infection. Okay. As a summary, with Medtronic DBS, you are getting personalized therapy, comfortable therapy with the thinnest recharge-free and rechargeable DBS neurostimulators available, ready for future enhancements with that software upgrade that we talked about. And as Luke just spoke on, enhanced MRI access to 1.5T and 3T with the ability for therapy to remain on during your MRI scan. Okay, so what can you do next? If you're interested, you can scan this QR code and you can sign up to receive more information about DBS. We have a Facebook community, and there is a center here in Sarasota at Sarasota Memorial. We have a surgeon there that does DBS. I'm the local rep here in Sarasota, so of course, if you have any questions, I'm around. I'm happy to answer those for you. And also, if this presentation spoke to you, if it aligned with you, if you're really thinking about DBS, talk to your doctor about it to see if they have information, and if you can, they can help you determine if you're a good candidate and in that good window of opportunity. Okay. That is
Any
all.
questions? Yeah, it's a good question that gets asked a fair amount. And the nice thing about DBS is we always tell people you can do pretty much every activity, just do them in moderation, right? If you're going to do boxing, that's perfectly fine. Just don't go in the boxing ring and try to take someone out, right? That's a different story. But boxing, sparring, golf, tennis, pickleball, those things are all open to be done. If you're going to go do exercise, we know exercise is actually the number one thing that we know that can kind of stop the progression. If you keep on it, at least delay it. If you're going to grab big weights, just don't do a lot of over the head kind of weights, right? Try to keep things shoulder level. And the reason why I say this, because if you really try to go hard and heavy and you somehow come on your head, over your head, and you hit the area where they've spent a lot of time and effort to place a good lead, that'd be kind of an unfortunate scenario. But there really isn't. Let me tell you the things that I know we are not supposed to do. Scuba diving past 33 feet, okay? Skydiving. If you had that on your bucket list, you might have to cross it out. And the only reason skydiving's on there is because if you've ever done it, when you jump off the plane, you're obviously falling at a very high speed. But when you deploy the parachute, you have this, it kind of yanks you up, and sometimes the strap can be quite aggressive, and we just don't want this area to be affected. But apart from that, we have professional golfers that are still playing golf with this device. I know golf is not the type of exercise you're talking about, but tennis, pickleball, all of these things are, if you have one in mind, I bet you I can say you're going to be fine with it. Yeah. You had a question. Are you saying after you have DBS, or if you had DBS and you got sick, is what you're trying to say. Yeah. So anything like that is not going to affect the system. All right. You're going to experience that sickness like you would if you had DBS or you don't. All right. If you get the flu, you're just going to have those symptoms. So it's not going to change that part of it. And it's not going to affect the DBS. Like anything, if you think about it today, if you have Parkinson's and you do get sick, it can really exacerbate some of the symptoms that you're feeling, right? And getting sick is actually a big problem. Like going to a hospital because you're sick, and the people at the hospital don't quite know how to treat Parkinson's, or may not know that you have Parkinson's. There's a lot of information out there that talks about how a hospitalization can set you back a fair amount. So it's important that our healthcare providers at the hospital know that you have Parkinson's, right? Because they may handle the situation differently. Yeah, that's a good question. Yeah, anything with electrical. So first of all, let me answer. We have patients that have both pacemakers and DBS. In fact, when you see some of our most patients today, you'll notice they have their device on the right side, of the possibility of ever getting a pacemaker down the road. There's a lot of considerations that you need to have. If you're ever going to go have surgery post DBS, let's say you have DBS and you had a fall and you break your hand and you need to go have surgery, we turn the device off before you have surgery because they have electrical components that may interfere, and so they just turn it off and turn it back on. At the end of the day, if you're going to use something electrical on you, we always tell people, call Medtronic, make sure it's fine, that you can do it or not. For the most part, because DBS has been around for so long, and nowadays technology, I feel like there's a new technology that comes out every other day for, with stimulation patterns, for massaging or for, TENS units. They have all these things. Well, we haven't tested all of those, right? Because they're all new, but we can always associate it back to something we did test it with and say, hey, this is similar than what we did before. If you're going to do it, just start low, try it out. If you feel like there's an interference, then you stop doing it. When you say interference, you're not going to turn it on and something really bad is going to happen. You may feel like, oh, I feel like a tingling that's not normal. You probably should stop doing it. Yeah.
So prior to implant, as part of the candidacy selection process, patients will go through a neuropsych exam to determine if they are a good candidate for DBS. Yep. In the first place. So typically patients with cognitive decline aren't good candidates just because there is the potential that, implanting something in the brain and going in the brain has the potential to make that even worse. So, but there's all that testing that's done beforehand, surgical consults and everything to ensure that everything will run smoothly. Mm-hmm. Correct. That's a good question.
So I can tell you this, someone that does not have DBS, right? There's different types of medications, right? You may go to sleep and you just took a carbidopa, levodopa, but it has a certain, half-life and it runs through your system. By the time you wake up, you don't feel too good. And then you take your next pill. Or you take a continuous release and hopefully that'll hold you throughout the day. You still experience a lot of, well, not everyone, but I know in talking to a lot of patients with Parkinson's, get up throughout the night a fair amount to either go to the bathroom, right? And that can be a struggle. The difference between DBS is, unlike medication that has this peak and then goes away, it's in your body all the time. And now it's adaptive, right? And so it'll recognize if you need a little bit more or not. So if you're sleeping, typically you don't need to, right? You don't necessarily need as much, but you need some, and it'll still provide you some. But then when you wake up to go to the bathroom, it'll automatically ramp up to try to help you get back on while you go to the bathroom. So I would venture to say that sleep improves for people because you have something 24/7 in your body.
Mhm.
Yeah. What's that? Yeah, in many ways, yeah.
Mhm.
Yes.
Yes. So yes, typically, like as we talked about with the process, you would have that initial programming with your movement disorder neurologist or the neurologist that had referred you for DBS in the first place. Once you're optimized and we find the good settings that work for you, typically for your DBS, you may only need to be seen by them once or twice a year. Ultimately, that's a decision made by the clinician. But yes, it is monitored, but it's not. No, so I believe that's a pacemaker thing, right? Yeah, we can't like pull data from it out of nowhere, like the cloud or anything. Yeah, it's just when you're in the office with the clinician that we can interrogate the device and pull the data from it in person.
With that being said, uh, I would be very surprised if we're not there soon. And that's because, well, you see how it is, right? We all technology is so much faster in developing these days. Um, this cloud-based data is now very common, but it's all patient information and HIPAA violations, and so it's not an easy thing to tackle. But remote programming is something that's around the corner that people can do at some point. That still hasn't been perfected, right? Because people that live in remote areas may not have good connection. So these personal visits are important to have. But I'm sure eventually we'll get to that point.
So the question was, if the symptoms are advanced and we're past the window, is there still value of having the DBS? So
So the best way to answer that is have a good sit down with your movement disorder neurologist to talk about it. Okay. The reality is, if you're talking about an advanced Parkinson's, right? The importance of a screening is just so important, right? Which is, how is your cognition? You know, what other comorbidities do you have? Do you have speech issues? Do you have swallowing issues? Do you have balance issues, right? Memory issues. These all things can get worse if you get DBS during that state. Okay. So there are people that have advanced Parkinson's, but still are okay cognitively, right? Still are overall in good health. This is when a good center will go, okay, let's weigh the risks, right, versus the reward. And it's not uncommon if someone is on the edge of like, we can still get a lot of benefit of DBS, but there's always this risk. They may not do both sides. They may just do the one side to help your dominant side or your worst side, because at least that provides you, if you're right-handed and typically your dominant side is the one that at the beginning stages of Parkinson, when you get diagnosed, a lot of times it's the one that it starts with the symptoms. That's the side we want to treat so that you can have better quality of life, since you're going to be using that side more. So we can't emphasize any greater how important it is to go to a center that has experience with DBS. Sarasota has always had a good center with DBS. They've been doing it for quite some time. And there's multiple centers in Florida, right? But if you have a movement disorder neurologist that you trust, they typically partner up with the implanting surgeon, and they're the team with us to help you with information to let you know if it's a good idea or not.
great questions, you guys.
Yeah.
Anyone else? Good. Okay. Thank you.
Thank you, guys. I
Yeah.
appreciate it.
Awesome. I had some patient education brochures and materials in the back if anyone is interested. And then I'll also leave a couple of my cards up there in case anyone has questions.